I'm Suzy Plows, and it's my pleasure to be moderating today's Global Cafe, which is interprofessional education for the training of language mediators and health services, a case study from Italy, which will be presented by Dr. Federico Farini. So Dr. Farini is a professor of sociology at the University of Northampton, where he leads the Center for Psychological and Sociological Sciences. His current research explores three interrelated areas. The first area concerns intercultural and interlinguistic communication and mediation in health and education services. The second area relates to intergenerational relationships and how they inform adult-child interactions in education, healthcare, and social services. At the intersection between pedagogies, health professionals' identities, social care policies, and children's agency. The third area centers around the language of human rights as social semantics. Federico has published academic works in Italian, English, and Slovenian languages for international publishers. He is also a board member of CAPE. So, Federico, I will hand it over to you now. Looking forward to your presentation.
Okay. Yes, thank you very much, Suzy, much appreciated, and I appreciate your IT support. Yeah, thank you for that. And yes, so as introduced by Suzy, my background is interdisciplinary, and particularly in my role as a visiting professor at the University of Modena and Reggio Emilia, I am still working in the field of interprofessional education and developing and delivering training for intercultural, interlinguistic mediators working in healthcare settings. And my presentation today, next slide, please. Thank you. My presentation today would like to share my experience and experience of professional training for interpreters in Italy. In particularly this seminar discusses the interprofessional approach to training and designed and provided by a consortium of Italian university and in partnership with the regional health services of Emilia-Romagna, a region of Italy. And I have worked for over 15 years now, contributing to interprofessional education. And before sharing with you the training we've been delivering for many years now, I really believe it is important, and the first part of the presentation will be about that, to introduce to offer a conceptual introduction concerning the concepts of public service interpreting, the concepts of intercultural communication, the concept of language mediation. And the reason is that it is very important to share the meaning of these concepts in order to appreciate the aim and the value of the training. So next slide, please. Thank you. Public service interpreting. It is a professional and academic area, has been developing for 35, 40 years now, and it continues to be an important area of research and an intervention, particularly in, let me use this generic connotation of Western countries. PSI, public service interpreting, refers to interpreting which is provided in the context of public services, and addresses the main purpose is to address the problem of language barriers which can prevent migrant users from participating in the most important social context, such as healthcare, such as education, such as social services. Research, particularly last 20 years, research has been exploring how PSI can become intercultural mediation and how it can foster sensitivity and acceptance of cultural diversity. It has to be said that interpreting language mediation does not mean intercultural mediation. Of course, language mediation interpreting is essential in most circumstances in order to implement intercultural mediation. However, there are two different things. And next slide, please. The next few slides aim to quickly discuss what are the differences between language mediation and intercultural mediation, starting from definition of what is intercultural communication, or better, more modestly, and what is the concept of intercultural communication that underpins public service interpreting, therefore the training in public service interpreting as developed in Italy. So I'm going to use the word traditionally. Intercultural communication has been conceptualized in terms of encounter between different cultures, therefore taking very much an ontological perspective, in the sense that the idea is that cultural differences, they underpin cultural communication. So cultural communication is communication between different cultures. And the underpinning assumption is that cultural differences exist before communication. So before the encounter, cultural differences are already there. And this is a view that has been criticized as based on essentialist approach, and that sees cultural differences as givens in a way. So they come before action, they come before communication, but that has been criticized, and this is where public service interpreting develops by a more constructivist approach, saying that the idea that people's individual behavior is entirely defined and constrained by the cultures in which they live brings with it the risk of stereotypes, the risk of a static idea of cultures that overlook the fact that culture is dynamic, is fluid, and is continuously constructed and reconstructed in communication through interactions. An alternative understanding of intercultural communication sees culture as fluid, as contingently constructed in communication, in a way, an emerging view of culture. Okay, and an emerging view, therefore, of intercultural communication. Intercultural communication is constructed each and every encounter, and that can justify why, in some circumstances, cultural differences are very important and they do influence communication. In other circumstances, cultural differences seems not to be so relevant. And this approach sees intercultural communication as production of shared cultural assumptions, which are defined by our colleague Adrian Holiday as small culture. Small cultures are localized culture that are constructed through interactions, through communication. So this concept of intercultural communication, if combined with language mediation, interpreting, this is what underpins intercultural communication, which is language mediation and intercultural communication. Next slide, please. So language mediation involves the translation of information from one language to another, and it facilitates communication via translation, but it is not interpreting. It is not simply interpreting, because language mediation entails the transformation of the communication context, the context of communication. For instance, empowering institutional representative, healthcare professional, for instance, and migrants, empowering them as active participants. And in this way, facilitating communication is not a cold transformation of contents from one language to another. Quite the contrary, that action of linguistic transformation brings with it a change in the social situation. And that change of in the social situation, when it entails the empowerment of participants' agency, becomes language mediation. Next slide, please. And that challenges the traditional perspective, very strong in the art of interpreting, of interpreters as translation machine, who are expected to produce 100% exact rendition of the original utterances, and staying as true as possible to the original contribution. And however, research suggests that when interpreting is translated into practice, that mechanical translation is replaced by a situation where interpreters unavoidably, particularly we can use healthcare as an example, where interpreters, they play an active role. And research recognizes form of coordination of interaction, coordination of participation that are produced by language mediation. More explicit coordination when interpreters, by asking additional questions and by asking for clarification, they explicitly take the role of coordinator, which is already above and beyond the role of interpreters as translation machines. But even more importantly, and research shows that interpreters, as they become language mediators, they implement implicit coordination of interaction. Implicit means that there are no explicit actions such as asking questions, but interpreters, they make choices in terms of adapting the translation to what they see as the needs of the specific participant, and to add more content, to offer maybe contextual information, sometimes to withdraw from translating content that they consider to be maybe at the risk of creating confusion. Of course, I need to specify that I'm not saying this is right or better compared to a word-by-word translation. However, research suggests that this is what happens when interpreters work in the community, for participants such as, for instance, the healthcare professional and patient. Okay, next slide, please. Therefore, the coordination of mediated interactions, so interpreters becoming language mediators, provide the context for interpreters' agency. Research, as particularly the work of Claudia Angelelli, has identified several situations where interpreters become agents in healthcare setting. I have produced a sort of list of situations where interpreters become agents. They have an active role, not as translation machine, but as active participants, co-constructing meanings, establishing communication rules, paraphrasing or explaining terms or concept. So adding interactional work to the linguistic transformation. Okay, and this is what generates and the need of training, because of course that active role of interpreters who become language mediators includes choices, decision that would not be needed if interpreters played the role of translating machine. There are of course implication for the patient and the healthcare provider, and there are also ethical implication when it comes to select what to translate or what should not be translated, or when it comes to adapt, so to change slightly the contents of communication to facilitate participation, to clarify, to contextualize, to add content. So as public service interpreting, as in a way unavoidably, at least this is what research shows, and is underpinned by an active role of the interpreter as language mediator. This is where the need of training emerges, and this is what makes training important, and what makes training necessarily interprofessional, interdisciplinary, because of course it's not only about interpreting, but it is also about, next slide please. It is also about the intercultural dimension. When language mediations happens in an intercultural context, it becomes intercultural language mediation or intercultural mediation. In intercultural encounters, the role of PSI is to coordinate communication processes. It is to promote equal relationship. It concerns promoting patients' understanding, which is essential for them to participate actively, to have their voices heard. Next slide, please. So I'm going to be quite try to synthesize the next few slides, because I have shared with you the main message when it comes to the concept of intercultural mediation. I can offer you examples, for instance, using Angelelli research, and what has been observed is that interpreters' translation is very often an adaptation of, for instance, doctors or nurses, midwives' question, and an adaptation that aims to transform those questions in questions that are more understandable to the patients, by contextualizing what are the expectations of the healthcare providers, recontextualize them in the culture of the of the patients. A classic example is that Angelelli works in the United States, that healthcare professional questions are underpinned by medical culture centered on the precise measurement of pain. This is an argument. While the interpreters know that the exactness in measurement of pain might be not prioritized in the patient culture, and therefore they adapt the question and they adapt the answers accordingly. And this is an example of the active role of interpreters that brings with it responsibility, and I know I'm repeating myself, the need of training. Next slide, please. Thank you. There are other examples, and I would like to bring just quickly an example from the United Kingdom. Ian Mason, nearly 20 years ago, and research work with Polish immigrants, immigration officers, and interpreters. And he observed that in a similar way, Angelelli observed in healthcare settings that even in these other type of institutional settings, interpreters were continuously adapting the content exchange in communication. So interpreting and modifying in order to facilitate participants on understanding, and in order for participants to understand better the context, the institutional context, the needs of the institution, but also for officers to understand the needs of the immigrant in a continuing cycle of clarification, adaptation of cultural meanings that really depends on interpreters' engagement, sometimes in side dyadic sequences, so spending some time with the immigrant or with the immigration officers, so creating some sort of ancillary interactions in order to secure that there is mutual understanding, which would be something absolutely forbidden by the traditional approach to interpreting, where the construction of side dyadic sequences would be seen as an unacceptable expansions of the interpreter's work. Next slide, please. So I am proposing you some example of PSI in action. So they are example taken from research in Italy, the same research or the same researches, because there is a very important corpus of research. And that research that was used then to develop training. And because the training I'm sharing with you is, of course, led by research, as well as led by interdisciplinary collaboration. So in this example, and it is an encounter with a female midwife, a pregnant Arab-speaking patient, her husband. Contextual note, very often husbands join the encounters, and a Moroccan female mediator. Okay, so this excerpt is taken from the closing phase of the visit, and it follows the midwife's explanation of future blood test. Midwife is OBS, is signaled as obstetrician. The mediator is MED, and the patient is PAT, patient, mediator, and midwife, obstetric obstetrician in English. So we can see the example where the patient observes a difference between healthcare in Tunisia and in Italy in turn one, And the mediator, what does the mediator do? The mediator does not translate and benefit of the midwife as an interpreter is supposed to do, the traditional approach, but the mediator creates this dyadic sequence by telling the midwife that in Morocco it is the same as in Tunisia, and only after that she translates for the midwife, who then confirms that yes, indeed there is a difference between Italy and Morocco or Tunisia. And only after that, term 7, so 6 terms after the initial contribution from the patients, the mediator translates the midwife's utterance. Next slide, please. And very interesting, turn 8 and turn 10, the mediator, the linguistic mediator, expands the contribution, the original term from the midwife to explain how the Italian system works. So she's adding information that was not provided by the healthcare professional. Again, that would be completely against a traditional approach to interpreting. That brings with it choices and responsibilities for the interpreter. There is a form of coordination to facilitate mutual understanding, filling gaps in this example in patients' medical knowledge and including knowledge about organizational aspects of Italian healthcare, and again, as I said, coordinating mutual understanding. And this approach is not unique to this example. It is by far the most common approach. And that showing that intercultural mediation, so language mediation in intercultural context, it really changes the medical encounter. It changes it by transforming the contribution of the main participants. For instance, as in this example, offering clarification of expectation, as I said, filling gaps in knowledge, and therefore moving completely away from a mechanical technical approach to translation. Next slide, please. Thank you. So this slide, so I chose to add this excerpt from another medical encounter. I removed the Italian original, I just signaled, because otherwise it would be too long and slides would have been too dense. And I have chosen this excerpt because the role of interpreters, language mediators, to be precise, as active participants who have a very important impact on the development of the interaction, therefore, of the medical encounter emerges powerfully. And here we have an Italian doctor, doc, and we have parents of a recently born baby. Pat is the patient, is the mother. HUS is the husband, and the mediator is a mediator med from Nigeria. The couple is from Ghana, and the encounter is about providing updating the parents about the health of the newborn, who had suffered very serious postnatal problems. And here in turn 1, in a very long contribution, the doctor explains that it is explained to parents that it is important for them to be aware of the possible negative outcomes, the baby conditions, the mediator in turn to see, yes, that is called an acknowledgement token. So acknowledges her understanding of the doctor's contribution. Next slide, please. And but then what happens is that in turn 3, the doctors continue the contribution. The mediator turn 4, for instance, does not translate. She waits for the doctor to continue in his contribution, which is very uncommon in interpreting, because interpreting is about translating sentence by sentence, really. So the doctor continues in turn 5. Next slide, please. And here, in turn 6, what happens is that the mediator translates the doctor very long explanation. However, the mediator, at the same, by doing that, the mediator had a lot of information that was not provided by the doctor. This is an example of implicit coordination I mentioned before. The mediator takes the initiative to do what? To contextualize the experience of the children, convulsions in African folk medical culture. I have to say that the very generic geographical reference of Africa is very common in the corpus. This is actually, I feel it is a very generic reference, but this is the reference used. So turn 6, the mediator adds more content and adds more context, and taking the initiative of transforming in a very important way the doctor contribution in order to make it more understandable for the patient. Next slide, please. In turn 9, again, the mediator takes the initiative to focus on a specific and positive aspect of the baby current health. And therefore, what was the doctor's intention? To focus possible future negative outcomes is replaced by the choice, the mediator choice to focus on positive aspect, on the positive side of the situation. Of course, the aim is to reassure the parents. There are also there is also a sort of emotional alignment of the mediator with the parents, and bringing a reference to support from God, maybe rather than the medical intervention as the agent of positive outcomes. Next slide, please. And
yeah, Federico, real quick, I think you might be off by one slide. Are you looking at the slide that says implications of PSI? No.
No, I'm looking at the slide before.
Yeah, so that's what I thought. I think you were. So, are you looking at your screen now? Is that the one you look 7 to 11?
Yes, and okay, so we can also stay with implication of PSI, and I come to that slide right now,
Thank you.
because it was the previous slide was continuing on emphasizing the active role of the language mediator. So, and but what are the implications of such a PSI? Okay, PSI allows language mediation to become intercultural mediation. It supports mutual understanding, which is the foundation of active participation, and it does include the management of intercultural communication, and it adapts participant contribution in order to secure understanding, we had the example of the mediator filling gaps in their knowledge, in the knowledge of medical culture, and maybe bringing in the conversation also the migrant patient needs, and this is all positive. However, and there is a risk. Next slide, please. And the risk is entailed in the choice of not rendering doctors and patients utterances in an accurate way, and also mediator's choice brings within the risk of misjudgment. There are ethical implications related to the suppression or distortion of information in the process of intercultural mediation. So when language mediation becomes intercultural language mediation, that entails more responsibility and makes interpreting as a much more demanding job. And therefore, next slide, please. I'm coming to the training, and therefore, and the need of training in form of interprofessional education becomes very strong. So here, the next few slides, I'm going to share with you the ethos and methods of training practices for language mediators in Italy, in the region Emilia-Romagna, which is underpinned by the collaboration between professional knowledges of healthcare providers, professional knowledges, because they are so diverse, of linguistic interpreters, and the contribution of social scientists. Next slide, please. And this is related to a partnership between the University of Modena and Reggio Emilia and the healthcare services in the region Emilia-Romagna, that again, for over 15 years now, have collaborated in the provision of training for interpreters as intercultural mediators, and which is underpinned, as I mentioned, by the research. I've offered you some example of. Next slide. So what is an interesting characteristic of the training is that the training is related to the concept of sustainability. So on the one hand, there is the training in interlinguistic and intercultural mediation, but on the other hand, that training includes also the aim of enabling interpreters to become leaders, to become trainers of other interpreters. The trainer approach, which secures sustainability by multiplying the impact of training. And this emerges, next slide, please. This emerges very clearly in the organization of the curriculum. So we see the training is organized in 5 modules, which are listed here, and each module is led by different specialists, academic or professionals from the most diverse background. And next slide, please. Thank you. And the 5 modules develop over 1,500 hours, 300 hours dedicated to face-to-face teaching, 500 hours of guided studies, so mostly online activities, 400 hours of independent studies, their reading, and 350 hours of placement, which is most of the time in the organization the interpreters work for. You can see it's a robust training. This is more or less the size of a master's degree in the United Kingdom in terms the size, in terms of hours, and for 40 weeks, so it's an academic year. Specific case, it takes place on Friday, all day on Friday, 9 to 5 or 8 to 5. The choice was motivated, to give a bit of context, because it was easier for participants to arrange with their employers, the possibility to attend the training. In terms of numbers, and there is a cap, is 35 participants, is always completely subscribed, and it's been like that for 15 years now. Next slide, please. And I want to quickly go through with you the different modules, also to identify what are the different knowledges that contributes to the module and that give substance, reality to the interprofessional ambition of the training. The module 1 is a module where anthropologists and people from law and educationalists work together, because, for instance, there is an aspect that concerns anthropology that relates to the multi-ethnic nature of our society, but there is also an aspect that concerns law, which is the international legal framework and the rules on immigration, and there is the aspect that concerns immigration policies and the impact on the and the impact of a healthcare system or on welfare. There is the aspect, and that brings educators in, that concerns particularly working with children, the aspect of socialization and education. Next slide, please. The second module sees the intervention of sociology, working with law, working with public health, and with organization studies, because that concerns, on the one hand, citizenship's right in a multi-ethnic society that are related to health, the right to health, and now it interacts that right with healthcare models towards we can call it immigration medicine, which can bring intercultural conflicts sometimes, and misunderstanding and discrimination. So this is where sociology and social anthropology they play their parts. Next slide. The third module is based on the contribution of psychology and public health, epidemiology, and psychiatry, and it concerns the important aspect of mental health and well-being, and that concerns the psycho-emotional framework and of intercultural communication in healthcare context, that brings also issue related to the second generations, and brings issue of epidemiology, and brings therefore how aspects that relates to epidemiology can be influenced by prejudice, inequality, and how that can be related to social psychology and aspect of group membership and identity. Next slide, please. The fourth module is very much concerned with being in Italy with the with the SSN, which is Sistema Sociosanitario, is the equivalent of the NHS in England. So for participants in the training to develop full understanding of the organizational aspects of the SSN, and therefore how they are positioned in the in the different organization within the SSN. But this is also connected to aspect of welfare, to aspect of intercultural communication, which then includes references to the religious aspect in a multi-ethnic society, and that also brings aspect of different communication styles, and this is where interpreting comes into play, where ethical aspect comes into play. So there are philosophers, ethics is a branch of philosophy, of course, that give their contribution with organization studies and religious studies. Final module, next slide, please, is the module number 5, that is probably the most directly related to the idea, to the approach of training the trainers, because participants are supported in developing an understanding of research in healthcare. So being able not only to read and understanding research, but also to plan and implement research project, then can support their role as leader. It may be adjusting, developing services, and research in intercultural context. Another aspect, the aspect of andragogy, because in their role as trainers of interpreters, of course, the aspect of andragogy, so teaching to adults and training methodology is an important component. Next slide, please. Which is for me to say thank you for your attention today. And of course, I'm available to offer more information about this very comprehensive, ambitious, and successful example of interprofessional education dedicated to train, to educate professionals such as interpreters in their role as intercultural mediators, based on the acknowledgement that their role goes beyond the one of automatic translating machine, and the aim of this training is to make sure that their agency, which research show is inherent, is embedded in their work, their agency, however, and while supporting and promoting mutual understanding and therefore active participation of all individuals involved in the medical interactions, but at the same time that agency does not generate issues, problems that can damage, of course, the patient first, but that can damage the provision of intercultural healthcare. This is why the training is so articulated, is demanding, demands time, demands commitment, and but I can share with you, as I mentioned already, that it's been very successful, and now we see generations of intercultural, interlinguistic mediators that have developed from the work as training of the first cohort of interpreters. And this is, although in a financial point of view, of course, they can be seen as competitors from to the training that makes the team, myself, very proud and happy, because this is generating positive social impact. So again, thank you very much, and it was a pleasure to share my experience. And apologize again. I apologize again for the slight delay due to my difficulties in managing Zoom. But thanks to your support, that again, I think that in the end it went well. Thank you very much.
Thank you, Federico, very much. Enjoy the presentation. I think highlighted the importance of the interpreters and their role in providing patient-centered care, and how we can do that better and improve that interprofessionally. So I think to throw it out, we're kind of cutting it tight on time, but we started a little bit late. So if we have a question or two, and then see if we can, if anyone's got any. Don't have anything in the chat, but if anybody's joined.
What do you think the impact of AI, artificial intelligence, in these processes?
Yeah, okay, so this is a very pertinent question, because even before AI, there were already software available to, in a way, replacing really, because I mean, the aim was to save the organization, saves money, organization. And AI is emphasizing this aspect. I can, because I mean, I work with interpreters each and every day, and there is some concern also related not only to jobs, of course, but also related to the fact that that aspect of mediation, of contextualizing and recontextualizing communication in order to facilitate the engagement and participation of the different individual in the medical encounter, or can be any other sort of setting, that cannot be provided by artificial intelligence at the moment. Artificial intelligence can translate perfectly, can also, based on the underpinning database, proposing some different form of translation, but the aspect of mediation, the role of the interpreter as a mediator, as a bridge between culture, a bridge which is, however, adaptable, can change shape, length, and form according to how the interaction develops. That cannot be offered by AI. Therefore, while on the one hand there is some concern, on the other hand, I can share with you that in the community of interpreters, mediators, there is still a firm belief that at least for now, AI won't be able to replace them and won't be able to make a difference in intercultural, interlinguistic mediation. That's their position at the moment. Then, of course, if organizations choose to use AI to save money and overlooking the aspect of bridging culture, the aspect of adapting in a flexible way to how the communication goes, that would be their decision. But at the moment, at least in the context I'm familiar with, this is not cannot be foreseen at the moment. There are no signs that AI will come and replace the work of intercultural, interlinguistic mediators.
All right, thank you. So, Micheline, you have a question as well.
Yes, thank you. It was really very interesting. I am Micheline Yamin from Lebanon, and for sure the intercultural aspect is very important for us, because I'm sorry, my English is not so good, but I'm trying to explain my idea. I'd like to ask a question, because when we work with the intercultural thing, sometimes there's the limit is very thin between how to understand the culture and how to sometimes be subjective in French, subjective. So to sometimes change the meaning, because we understand so much of the person that we change a little bit the meaning of what the doctor could say. Could it be possible? And how do you face this problem? Or at least in your research, how are they trained for that? How to really stay strict on what the medical person, the doctor wants to say, and not what I want, because I understand what her culture and what she feels and whatever. I don't know if there's boundaries somehow.
Yeah, you are perfectly right. what you have described is exactly what happens, what we can see in our data, and but also many other researchers. This is what I mean when I mentioned the mediators agency in the sense of sociological concept of agency means making choices. The choices include changing the content of communication to adapt communication, but adapt to what? You are so right. Adapting communication to what are the expectations of the mediators, which bring with it the risk of misunderstanding, of course, and the risk of making mistakes. So what research suggests across the world is that whilst, for instance, let's talk about a conference, scientific conference, interpreters can follow the word by word model of renditions. When it comes to public service interpreting, that never happens. That never happens. It never happens, and the active role of mediator is very much visible, and it cannot be avoided. And also, as I said, there are benefits in it because sometimes it does support active participation, inclusion, and mutual understanding. But there are risks that you mentioned very clearly. So thank you for that. And training I have introduced aims also to limit that risk. For instance, there are sub-modules, so part of the modules. It didn't emerge clearly probably in the description, but it has to do with reflectivity, so reflection in action. So, but also reflecting as you interpret, mediate, but also reflection on action. After the encounter, there are techniques, there are models to support reflection, working with the transcript from the transcript of the interaction, peer observation, peer analysis of transcript, and interpreters as mediators, working with healthcare professionals to go through the recording and transcript. Of course, all the anonymity is all preserved, of course, to notice when there are areas that are problematic areas, when there are good practice, bad practice, best practice, worst practice. So there is the continuing dialogue that is embedded in the training, but also in professional practices to the guideline of the healthcare service of region Emilia-Romagna. Not everywhere in Italy is regionalized, the healthcare service. Of course, it goes without saying, the healthcare services in the region, they are investing a lot of resources in that. Somewhere else, that doesn't happen at all. And therefore, interpreters are not, mediators are not trained. They are chosen because they can speak the languages, but there is no training to support them and minimize the risk of mistakes. And there is no research to identify best practices or aspects to be revised, improved. Yeah, so what I've just shared with you, and that concludes my answer to your question, is that what I share with you needs investment, needs to be prioritized, needs investment, which is ultimately it is a political choice in terms of funding the healthcare system. But yeah, I hope I answered your question. But I also expanded, but I hope I answered your question.
Thank you.
Thank you. Thank you, Federico. So I think we need to just wrap it up now, but I think you had left your email. So if anyone has any additional questions,
absolutely.
they can ask you. That would be great. So thank you very much for your presentation today. I think it was enlightening. And yeah, it was wonderful. So thank you.
Just a quick note to say, I'm also happy to share. I'm not jealous of papers, reports, and so if anyone to read something and email me, I'm happy to email and send materials, okay, that talk about research and more reflection on the role of interpreters as intercultural interlinguistic mediators. Sorry, just
Yeah, no, wonderful. Thank you very much.